A patient presents to you with a painless lump on his eyelid that grew slowly over a few days. The deity that you are going to consider here is a Chalazion, because Chalazion is the most common cause of lid lump. Namaste. Our topic for today is Chalazion. What is a Chalazion? You can see it from this figure. Chalazion looks like this. It is a chronic, non-infective, non-suppurative lipogranulomatous inflammation of the meibomian gland. The term non-infective is important here because it helps it to differentiate from STI. STI is an infective pathology, and also lipogranulomatous inflammation and meibomian gland are important terms here. Let's look at the etiopathogenesis. The story begins with a mild-grade infection of the meibomian gland. This mild-grade infection can be due to low-virulent organisms such as S. epidermidis, and also it can occur due to Staphylococcus aureus. Due to this infection, proliferation of epithelium and infiltration of duct wall occurs. Now, due to this infiltration, these ducts become blocked. Due to the ducts being blocked, the secretions of the gland cannot exit the gland, and retention of secretion or the sebum occurs. The retention of secretion can cause enlargement of the gland, and also it can act as an irritant. If it acts as an irritant, it gives rise to non-infective lipogranulomatous inflammation. We are using the term non-infective here because it is not the organisms that are causing the inflammation. It is the secretion which is acting as an irritant. The main presenting symptom is the one which we have discussed at the beginning. That is, it causes painless swelling in the eyelid, which gradually increases in size. Next symptoms are mild heaviness in the lid. This heaviness will be felt with a moderate to large chalazion. Patient can also present with blurred vision. This can be seen occasionally due to induced astigmatism. This occurs with a very large chalazion that presses on the cornea. Next symptom is epiphora. Epiphora is watering of the eyes. It can occur sometimes due to eversion of the lower puncta. Looking at the signs, we will see how the chalazion is appearing. So, the nodule is noted slightly away from the lid margin. It is firm, hard, non-tender, and upper lid is involved more than lower lid. Why is it so? Because upper lid has more amount of meibomian glands. When we evert the eyelid, we can see reddish purple area, which points towards the chalazion, and it is seen on the palpebral conjunctiva. It can also occur as a marginal chalazion, which occurs at the margin of the lid. Looking at the clinical course, it can either completely resolve spontaneously or slowly increase in size can occur, or it can lead to complications. The complications can be fungating mass of granulation tissue, now this is formed when the lesion bursts on the conjunctival side. Next is secondary infection. It can lead to hordeolum interna. Next is calcification. This is rare, and malignant change. It can lead to adenocarcinoma, that is sebaceous cell carcinoma in elderly. Let's go to the treatment. First, we try conservative treatment. In conservative treatment, we can do hot fomentation, topical antibiotic eye drops, and oral anti-inflammatory drugs. Next, we can give intralesional injection of long-acting steroid. The steroid which we will use here is triamcinolone. It can cause resolution in 50% of the cases. Also, we use them in cases where incision and curettage may cause damage. Third is incision and curettage. The most effective treatment is incision and curettage. For this, we give surface anesthesia. We use xylocaine drops. We instill them in the eye, and in the lid where the chalazion is present, we infiltrate it with 2% xylocaine solution. The chalazion is here, so we will put the incision here. The incision is made with a sharp blade, which should be vertical on the conjunctival side. Why vertical? To avoid injury to other meibomian ducts. And on the skin, it should be horizontal. Why? To avoid invisible scars here. Next, after the incision, the contents are curated out with the help of a Chalazion scoop. After this, to avoid recurrence, carbolic acid cautery followed by neutralization with methylated spirit is done. Then we do patching of the eye after instilling eye drops for about 6 to 12 hours. Then we give some post-op treatment to decrease discomfort and prevent infection. That is again hot fomentation, antibiotic eye drops, oral anti-inflammatory analgesics, and oral antibiotics. We give that for 4 to 5 days. The fourth option which we have is diathermy. This is preferred for a marginal chalazion, and then oral tetracycline. This is given as a prophylaxis in recurrent chalazion, especially if it is associated with acne rosacea or seborrheic dermatitis. So that is all about chalazion. Thank you.